Do we need to?
Some patients you do and some patients you don't. Let me go grab one so you can see it. I'll keep talking. What y'all gotta understand is saline is another big debate going on right now in respiratory. And that there's a group of therapists who say that you should not ever use saline on your patients. Mainly because it is irritating to the airway. And their argument, which is legitimate, states that over time that you have a patient intubated, you develop what's called biofilm in the inside of the ET tube, which is basically just a small invisible film of bacteria and funk. So when you put saline down and then you bag, what did you do? Washed it all into the lungs. Yes. So they're thinking that that might be a cause of VAP, ventilator-associated pneumonia. Why do you need to care about VAP? Because you are probably one of the #1 contributors of VAP. The other thing you need to know about VAP is part of PPACA. Do you know what PPACA is? AKA Obamacare. You're not allowed to call it that in this class. You call it PPACA. Stands for Patient Protection and Affordable Care Act. But part of PPACA and healthcare reform is that over the next 5 to 10 years, they are going to stop paying for certain incidents. VAP is #1 this year. So in other words, and Medicare had started doing this a long time ago. If your patient comes into the hospital and does not have a pneumonia, and they get a pneumonia while they're on a vent, that's a VAP. Medicare does not pay any of that patient's bill, whether it was a $6,000 bill or a $6 million bill. They just don't pay for it. They say, oh, you messed up, we're not paying your hospital. So then guess what? The hospital loses money, so you don't get a raise next year. So it does affect you. Every year, they're going to start adding, and the new standard is the patient cannot be readmitted within 30 days. So if you have a patient that has bypass surgery on their heart, and they come back 30 days later, they don't pay for either admission.
So make sure you're not readmitted to the 31st day.
The bad thing is, and the hospitals are having to be proactive on that, because part of the argument, and I know this is off subject, but you need to know this, that the hospitals are having is we cannot control what the patient does in those 30 days that they're at home. So if I discharge this patient who just had heart bypass surgery, and they stop at Circle K on their way home and get a case of Bud Light, a carton of cigarettes, and then they stop at Popeyes and get a 20-piece bucket, how do I have control over that?
Right.
And then they don't take their meds. So it is kind of in a way not fair to the hospitals.
And a hospital can't turn them down. They
No,
have
you
to
can't.
take them. There's
Exactly.
another law there that they can't
Exactly.
turn them down. So they get
So
screwed. either
the
way.
hospitals are fighting that part of it to say, you know, I don't have control, but like certain hospitals are trying to be proactive. Like West Jeff has a nurse that for all of their like COPD and chronic lung patients, her whole job is she calls those patients every day at home and says, did you take your medicine today? Do you need anything? Can I make you an appointment with your primary care physician?
Stay away from your Popeyes.
Because that's the whole thing. If I can send you to your primary care physician before you get really sick and prevent you from coming into the hospital actually justifies
There's
her
a lot of
salary.
liability on them.
It is. Okay, so back on this.
I have a question about that.
Yes.
You said saline solution, and then if you pre-oxygenate it, why would you put saline solution and then pre-oxygenate? Why would you
Because the
pre-oxygenate
point of the
suction?
saline is to, and that's, it's not necessarily oxygenating. If you're putting saline in, we say you want to bag it in, because the issue is, you can put the saline in the tube, but the reason you put saline is maybe because the secretions are too thick and hard to get out. When I need to get the saline down where the secretions are. So we bag it in to kind of loosen it all up.
You have to bag it in there, and
Yes.
they're disagreeing with that part.
And I agree, like some of them are saying, well, you're washing the biofilm in and that could possibly be a cause of that. But as a working therapist, there are just some patients that you need to use saline.
So that is the correct order that they're doing it, unfortunately, it's.
Right. And it's not a proven thing, but just so you know, you may run across some instructors and say, oh my God, we don't use saline. That's why, because
Then how do they get the secretions out? What do they use?
just suction.
Just a
And that's the
suction.
other point you gotta understand, guys. Don't be one of those therapists that just automatically dumps 3 cc's of saline in every patient. And you're gonna learn in today's lecture, which we have in 20 minutes, so we gotta hurry. when you suction a patient, don't be a robot, guys. Number one, does the patient need to be suctioning? If you agree that they need to be suctioned, I always do what I call going down dry the first time, meaning with no saline. That gives me an assessment. Does the patient have thin, watery secretions and I don't need saline? Or do they have thick, nasty secretions and maybe I do need to add saline? That's how you make your decision.
Thick, they'll get hard, right?
And then it
And
can
the
glue too.
humidification's not enough to,
Not all the time. I mean, if you have patients with like cystic fibrosis.
that's not gonna help.
It's not gonna help.
That's not helping.
Sometimes saline doesn't help me. Raquel, you okay? You're looking like you wanna shoot yourself.
No, I'm good.
Okay. If you're gonna shoot yourself, just do it in the hall. So we don't have to-
I was about to shoot me. You're about to shoot me.
Okay, so are we good with when to use saline, when not to use saline?
Yeah.
How do you know? Okay, so just so you know, guys, you undo the cap of the saline, and then we're not gonna put it down our ET tube, but it just sits right in here. Okay? So when you're going in, I'm gonna come stand over here, so I might have to get better angles. So if you're going in to suction your patient, first things you gotta understand is if you hold the catheter just like this and you pull back, a lot of times you're gonna pull it right off the airway. Okay, so the proper technique for holding the Ballard, I usually do it like this. That way I've got my hands on the tube, I've got my hands on the Ballard, I'm holding them together. Okay, so what are you gonna have attached to this end? Suction tubing, right? Which this 6 feet of suction tubing then plugs into the canister and the vacuum on the wall. Just making sure you understand that something does have to be plugged into that. You're not gonna put your mouth on it and suction.
You saw my face? No.
Never gonna happen.
Not today.
They would have to start paying us a heck of a lot more money for me to do that. Okay, so we're ready to start suctioning. We've already hyperoxygenated, hyperventilated our patient. So let's say I'm going down the first time dry. I'm gonna say if my patient's awake, okay, Mr. Smith, I'm gonna go ahead and suction your airway and get some of that mucus out. So I start pushing the Ballard in. Let's say that I've hit my obstruction, which I kind of have. Pull back about 1 to 2 centimeters. Then I want to apply suction, which one of the things I forgot to do was unlock my suction. The reason it has a lock on it is so if it gets pushed up against the side of the bed or something, it's not continuously suctioning the patient. So before you do that, you would want to unlock it to where now you can apply suction. So now I am going to apply suction and slowly withdraw. Notice I am a continuous suctioner. So let's say that I determine this patient has really thick secretions, I think I need some saline. After the patient has recovered, they're still connected to the vent, guys, so you don't have to stop and bag them. Let them get some breaths, let their pulse ox go back up to 100 or
That's
whatever
what you mean
normal
by let them
was.
recover.
Correct.
Okay.
Because you don't want to just jab it back in
Right.
right away. So what I'm going to do if I decide I want saline, first and foremost is you need to put your catheter in a little bit, okay? If you don't, if you just squeeze the saline right now, it's not going to go down the ET tube, it's going to go right into the vent circuit.
Gotcha.
So insert the catheter a little bit in the airway, squeeze however much saline you need. For adults, sometimes we can just go ahead and put the whole 3. For little ones, babies, NI babies, maybe just 1 cc of saline, okay? Squeeze my saline, and then I go ahead and continue the procedure. I hit an obstruction, pull back, and then if I wanted to suction intermittently, notice I'm pulsing the suction. Y'all see the difference?
I'm
Okay,
gonna see what it
If it's
says, the
thicker
route of
secretions,
saline
what would you suggest? Continuous or pulse?
continuous.
Okay.
So the route that the saline is taken, it goes through here.
Right, it exits through this, so that's why you need to have the catheter in the patient's airway. See,
Okay.
if you
To
pull it
stop
out, there's a little tiny hole.
Oh, I see that hole. Okay, I got you.
Okay, so like I said, you do want to put it in a little bit. The thing you need to realize with Ballard or closed suctions, you don't want to leave it like this, because if you look at it, the suction catheter is in theory a little bit still in the patient's airway. You want to pull out until you see that black mark. You see that? Get right there,
Black hole
Okay.
where?
okay? See the little black line right there?
Uh-huh.
You want to pull out till it's just about right there. You don't want to pull too hard, because if you pull too hard, guys, then the bag fills up with air if you leave it connected to the suction.
Okay.
So you don't want to have it like too taut, but you don't wanna have it right there either. So just right until the black line gets, some people even leave it on this side, which that's kind of okay, it's not too horrible down the airway. Okay, but you don't wanna ever leave like that much catheter in the airway, you're causing an increased airway resistance.
Right.
Are we okay with that?
Yes.
Okay, that's not your check off though. Damn, huh? A lot of the stuff we talked about is part of the check off. But we understand when to apply saline, how to put it in, we kinda understand